to our class today. My name is Negedu Godwin, and I'm going to be your facilitator for this course. So we're going to be looking at Introduction to Gynecologic Sonography. This acknowledgement goes to these wonderful people who have contributed to my knowledge greatly, which I appreciate. Now, when we do ultrasound for gynecology, basically we're looking at female pelvis. Yeah. So why do we do gynecologic sonography? What are the clinical indications for pelvic ultrasound? Now, evaluation of gynecologic complaints is one of those many reasons. Gynecologic complaint will include pelvic pain, dysmenorrhea, menorrhagia, metrorrhagia, amenorrhea, abnormal bleeding, post-menopausal bleeding, etc. You can also do pelvic ultrasound to localize and characterize pelvic masses that were noted during physical examinations. Follow-up of previously detected abnormality like hemorrhagic corpus luteum cysts or any other cysts that was noted in the previous scan. You do pelvic ultrasound to localize an IUCD, intrauterine contraceptive device, and any other complication around it. Screening for malignancy in patients with an increased risk for malignancy is an indication. Evaluation of suspected ectopic pregnancy. Investigation of fertility, like evaluation and monitoring of infertile patients. So general evaluation of pelvic anatomy is involved. Confirmation of ovulation, diagnosis of anovulation, ovulation monitoring, like folliculometry. During ovulation, inducing drug therapy, you do an ultrasound. Diagnosis and follow-up of endometriomas of the ovary. Now, in vitro fertilization is one of those investigation. Diagnosis of PCOD, as polycystic ovarian disease, and diagnosis of luteinized unruptured follicle syndrome, or diagnosis of Mullerian anomalies of the uterus, are all indication. So we also would do pelvic ultrasound in pediatric gynecology. That's evaluation of pelvic mass or any ambiguous genitalia, precocious puberty, and primary amenorrhea. Other indications will include bladder lesion and urinary stress incontinence. Evaluation of obese patients. So in such cases, you do transvaginal sonography. So further characterization of a pelvic abnormality that is noted on any other form of imaging like CT and MRI is an indication for pelvic ultrasound. Also, you do pelvic ultrasound where you have abnormal lab values. For example, maybe you have a lab value high CA125. So what are the scanning technique that we usually would do in gynecologic study? Now, there are several techniques for evaluating female pelvis. These include taking good history and correlating it with laboratory tests. It's very important you take good history. You do transabdominal sonography. You could also do endovaginal, what is called vaginal sonography. You could do transperineal or translabial sonography. Transrectal sonography is also there. You could do to evaluate pelvic scan, sonosapinography, or sonohysterography. So we talked about taking good history. You see, taking good history is very important so that you'll be able to recognize significant clinical information. A good history is to be taken before starting scan. We should include a good history will include these information such as last normal menstruation, history of unusual or abnormal bleeding, other significant clinical signs and symptoms. So you want to ask your patient if there are any complaint, if there are anything they feel or they observe in their body. So and also history of the previous surgery where such is the case. You want to know, and you also want to know medications, whether the patient is on medication or has been on medication, and also whether they are on IUCD. You want to take good history with respect to pain, the time of the pain, the position of the pain, the quality of the pain. In other words, you ask your patient to grade the pain from between 1 to 10 so that you can have an idea of the quality of pain they are feeling. Is this pain radiating? What is the severity? Good history will involve, will give you a good reason for the scan, because somebody walk up to the ultrasound room that they need a scan. The question is why? Why do you need an ultrasound? So such questions forms history collection. Result of previous ultrasound scan, if there is any, it is important you know so that you can work with the previous information vis-a-vis the time that it was carried out. Result of any additional diagnostic report. Remember, we're talking about CT scan, MRI, or any other information. Pregnancy tests and other lab data also information in your history that you want to know. Lab data that involves hormonal information, tumor markers, or any of those information. So it's important that a sonographer must be capable of analyzing the clinical history, exploring family history, correlates such history with clinical features, other laboratory data with sonographic finding, which will have a direct impact on the final diagnosis. So it's a whole lot of pulling together of information to deliver a good final diagnosis. You don't just scan, you need history to do so. That's what makes you a good sonographer. So what are the pertinent gynecologic history that is really important? Now the sonographer should know the patient's clinical history as much as possible. What and why the study is being requested is very important. You look at the request sheet, check out the indication and possible short clinical history that may be provided. And where it's not provided, please, you do your own clerking of a patient. Now, if the current study is a follow-up study, the previous finding, the films from that previous finding should be reviewed prior to the beginning of the study, of the current study, to ensure that the clinical concerns are being addressed. So you don't jump into current study without understanding what the previous study was. And it's professional to do that. You study it ahead of time before the patient, where it is available. So, clinical study and other terminology that are helpful to a sonographer would include the patient's age. Many gynecologic problems are age-related, so you want to quickly know how old this patient is. Patient's age may be helpful in considering differential diagnosis that's associated with sonographic findings. You want to know the menstrual history, the start of the normal menstrual period, the regularity of the cycle, duration and amount of flow, and presence of cyclic pain or mid-cyclic pain may be helpful in your differential diagnosis. Pelvic pain is very important. It may be the only symptoms or may be associated with other symptoms such as vaginal bleeding or adnexia mass, ectopic pregnancy, PID, endometriosis, ovarian torsion, adenomyosis, acute salpingitis, or acute appendicitis are typically present with pelvic pain. Dyspareunia is painful. This is pain that is associated with intercourse. It is commonly associated with endometriosis. Palpable mass, location of the palpable mass, example like right adnexia or ovary, with relevant information such as the age of the patient, whether it's symptomatic or symptomatic. Such as whether there is pain, menstrual disturbances. These are all helpful informations in your diagnosis. So the most common pelvic mass is the ovarian cyst and uterine fibroid that we see around in our client. So the less common pelvic masses are tubal ovarian abscess, pyrosalpinx, hydrosalpinx, pelvic kidney, and so on. So in the patients with positive pregnancy tests and or amenorrhea, it may represent ectopic pregnancy or corpus luteum cyst of pregnancy. So it's important you understand these terminologies and understand how they interplay so that you come up with something of great value. So ultrasound is usually able to confirm the presence of a clinically palpable mass. Ultrasound can determine the origin of the mass. For example, whether it's arising from the uterus, whether it's coming from the ovary or other pelvic structures. Ultrasound can measure the size of the mass accurately. Ultrasound can describe the morphological criteria of the mass. Now, if the mass is a solid mass, cystic mass, or is a complex mass, ultrasound can accurately determine or detect the presence of fluid in the pelvis. However, ultrasound is generally unable to determine if a mass is benign or malignant unless there is evidence of invasion or metastasis. Ultrasound is unable to determine on only one study if a small ovarian cyst is physiological cyst or pathological. So you have to do a battery of ultrasound study to determine whether it's physiological or pathological. So what are the key, I want to introduce the key ultrasound terms that you would see and relate with almost all the time. So the first one is adnexia, and adnexia is actually the area located posterior to the broad ligament adjacent to the uterus, which contains ovaries and fallopian tubes. Amenorrhea means the absence of menstrual period. Dysmenorrhea means difficulty or painful menstruation. Dyspareunia is painful intercourse. Hypomenorrhea is decreased or scanty menstrual flow. Menorrhagia means abnormally heavy or prolonged menstruation. Metrorrhagia is the irregular menstrual bleeding that comes between periods. Menometrorrhagia are heavy and prolonged bleeding between periods. Ectopic pregnancy is a pregnancy located outside the endometrial cavity of the uterus. Very important to know in patients who present with amenorrhea or a positive pregnancy test. Patients with history of ectopic pregnancy are at risk of another ectopic pregnancy. Endometriosis. These are functional ectopic endometrial tissues located outside the uterus. Now, patients are at risk of fertility and ectopic pregnancy in such a case. Endometrioma is a benign blood-containing mass or tumor that forms from the implantation of ectopic endometrial tissue. The mass is associated with endometriosis. While adenomyosis is implantation of endometrial tissue into the myometrium of the uterus. Now, hirsutism refers to the excessive hair growth in women in area where hair growth is normally negligible. Infertility refers to the inability to conceive a child at 1 year after 1 year of unprotected intercourse. The patient may be at increased risk of ectopic pregnancy. History may be helpful in diagnosis of PCOD or endometriomas. While PCOD is a syndrome characterized by an ovulatory cycle, infertility, hirsutism, amenorrhea, or oligomenorrhea. And also you see that in obesity. And PCOD is also known as Stein-Levitan syndrome. Precocious puberty. This is a puberty development before the age of 8. It is the early development of pubic hair, breasts, or genitals. Virilization refers to changes within the female that are caused by increased androgen, leading to deepening of the voice and hirsutism. May be seen with Sertoli Leydig cell tumor, or what you call androblastoma. PID refers to pelvic inflammatory disease and is an infection of the female genital tract that may involve the uterus. If it involves the uterus, that's endometritis. If it involves the fallopian tube, that's appendicitis, or pyosalpinx or hydrosalpinx. When it involves the ovaries or any other adnexia or pelvic structure, then you are likely suspecting tubo-ovarian abscess mass complex. Now, patients are at risk of infertility in PID and also ectopic pregnancy. Pseudomyxoma peritonei is an intraperitoneal extension of mucin secreting cells that result from rupture of malignant mucin ovarian tumor or a malignant mucinous tumor of the appendix. Meigs syndrome is ascites with pleural effusion in the presence of some benign ovarian tumor such as fibroma or thecoma. Alpha fetoprotein is a protein produced by fetal yolk sac, the GIT tract, liver, and kidney may also be produced by some malignant tumors. Example like ovarian yolk sac tumor. CA125 stands for cancer antigen 125. Now, it is a tumor marker in the blood that can indicate certain types of cancer of the ovary. ACG is human chorionic gonadotropin, is the hormone produced by trophoblastic cells of early placenta and can also be used as a tumor marker in non-gravid uterus, and especially where you have this geminoma, yeah. And also you find HCG in males where you have choriocarcinoma of the testis. This is referenced in one of our blog posts. I will put the link in the comment section so that you can take a look at it. Tamoxifen is a breast cancer drug that inhibits the effect of estrogen in the breast but may cause endometrial hyperplasia or carcinoma. DES or DES exposure, it refers to diethylstilbestrol exposure of a fetus in utero and is associated with Mullerian defect like congenital uterine anomaly, infertility, and recurrent pregnancy loss. Asherman syndrome refers to intrauterine adhesion or synarchy, may lead to hypomenorrhea, infertility, habitual abortion, and may be helpful in the diagnosis of uterine adhesion with sonohysterography or adhesion detected with early pregnancy. Cervical incompetence is actually a painless dilatation of the cervix in pregnancy resulting in habitual abortion or premature delivery. Patient may present with history of cervical sacrilege, which is actually a tape or suture which keeps the cervix closed until the pregnancy can be safely delivered. Endometrial ablation is a procedure to destroy or ablate the endometrium by laser beam or heat. That's thermal ablation using using a hysteroscope or to control heavy or prolonged bleeding, not responding to treatment. The endometrium heals by scarring. Yeah. Hysterectomy is a partial or total removal of uterus surgically. Laparotomy is a surgical incision of the abdominal wall. Metroplasty is a reconstruction. Is a reconstruction surgery for congenital anomalous uterus. Example, the urinification of a biconate uterus. Myomectomy is surgical removal of uterine myomas, especially in women who desire future pregnancy. Oophorectomy is either a uni or bilateral surgical removal of the ovaries of the ovary. Reason for oophorectomy should be known, especially it will be helpful to know if the ovary is not visualized. You need to find out if you don't visualize it. Ovarian cystectomy is the removal of benign ovarian cysts with preservation of the ovary. Now, cyst reoccurrence is very possible. Salpingectomy is surgical removal of fallopian tube. Commonly is unilateral for ectopic pregnancy, and bilateral for any radical hysterectomy that is being done. Salpingostomy or salpingotomy is a surgical opening of the fallopian tube for removal of tubal ectopic pregnancy. Again, the patient is at risk for ectopic pregnancy. Tubal anastomosis. This is done for the reversal of tubal ligation, and such patient is at risk for ectopic pregnancy. Tuboplasty, or you want to call it salpingoplasty, is a reconstructive tubal surgery for occluded distal or proximal fallopian tube. Patients in this case are at risk for ectopic pregnancy. So, what are the lab findings that are relevant to gynecologic sonography? Let's take a look. And these are very important because you want to be able to correlate lab findings with your ultrasound scan. So laboratory values that may warrant a pelvic sonogram are hematocrit. So low hematocrit level should be evaluated in cases of suspected ectopic pregnancy or pelvic trauma. White blood cell count. Elevated white blood cell count is usually associated with pelvic inflammatory disease or endometritis. Serum HCG is typically produced by a developing gestation and therefore most often indicate the existence of pregnancy. However, gestational trophoblastic disease or neoplasia, some are rare tumors like ovarian dysgeminoma in a non-gravid state may cause an elevated HCG levels. This is important to know. So you've scanned, you've done the test, you scanned, you didn't see anything, you've done the test, there is a positive HCG. So one of the things to suspect is the trophoblastic disease. Serum alpha fetoprotein. Ovarian yolk sac tumor may show an elevated alpha fetoprotein. Cancer antigen 125 is considered as a tumor marker for ovarian carcinoma. However, leiomyoma, endometriosis, and PID may cause slight elevation in the CA125. Serum lactate dehydrogenase is elevated with ovarian dysgeminoma. Pregnancy test in a patient with within reproductive age, the sonographer should know if a pregnancy test was done prior with urine or serum, and if it was positive or negative, especially if an early IUP or ectopic pregnancy is suspected. So let's look at the pregnancy tests and issues around it. Now you need to know that following fertilization, there is rapid cell division, mitosis of the zygote that results in the multiplication of cells, which will soon organize themselves into primitive structures known as the blastocyst. Now, the outer cells of the blastocyst are known as the trophoblasts. Yeah? The trophoblastic cells invade the endometrium and later differentiate into chorionic villi of the placenta. Now, the trophoblast secretes HCG, which is the basis for the use of chemical pregnancy tests. The presence of HCG may be tested in the urine or serum, and serum beta HCG is the most sensitive early positive result that indicate the presence of pregnancy. The serum beta hCG test may be positive as early as 5 to 6 days following fertilization. That will be day 19 to 20 of the menstrual cycle. That is to say, the beta hCG can be positive about 1 week before the end of the cycle and the expected onset of the next period, which will be about day 29 in a normal situation. So there are several standards that are used for measurement of the beta hCG. There is the second international standard, and it is the original measurement standard. There is the international reference preparation. It is the newer and purer standard. Now, a given numerical value of beta hCG would vary by a factor of 2 between these two standards. So you want to pay attention, especially when the lab results are coming, which is being used. For example, 100 IMAU per mils measured in the second international standard is equal to 200 IMAU per mils measured in the international reference preparation, is IRP. Now, beta hCG tests may be positive 10 to 14 days before ultrasound is able to detect an IUP, intrauterine pregnancy. So present threshold for detecting a normal intrauterine gestational sac with transvaginal ultrasound is 4.5 to 5 weeks LMP, that is day 32 to day 35. And with transabdominal, you can detect it at 5.5 to 6 weeks of the LMP. Discriminatory zone for this beta hCG, discriminatory zone for with transvaginal sonography, a normal intrauterine gestational sac should be detected in the normal uterus when the beta hCG value reach 1000 MIU per mils in the second international standard. And of course, remember, it is times 2, which is 2000 MIU per mils in the IRP. But with transabdominal scan, a normal intrauterine gestational sac should be detected in the normal uterus when the beta hCG value reaches 1800 MAU per mils in the second international standard, and or you can have 3600 MAU per mils in the IRP. Now, these values are referred to as discriminatory zone of beta hCG. Other gynecological laboratory tests procedures that could be found or could be done are cervical smears, also known as pap smear. Now, it is a screening test for cancer of the cervix. Now, what is done is superficial cells of the cervix are collected by a swab and stained with pap stain and examined microscopically. Now, if characteristic malignant cells are seen, it indicates an early stage of cervical cancer even before symptoms occur. However, a false negative rate is about 25%. Colposcopy, which is a procedure done for gynecology in lab, is the visualization of a visual inspection, of the epithelium of the cervix with stereoscopic binocular microscope that is called colposcope. This can recognize abnormalities of the cervical epithelium based on the morphologic change and better predict the histologic diagnosis which is then confirmed by biopsy. It is also used as an adjunct to test with pap smear. Hysteroscope is direct endoscopic visualization of the endometrial cavity using hysteroscope, commonly used for diagnosis of endometrial polyps, submucosal fibroids, uterine synarchy or Asherman syndrome, congenital Mullerian anomaly of the uterus, such as the septate or biconate uterus. It can also be used for endometrial biopsy and surgical procedures, such as excision of intrauterine adhesion or congenital septae. Dilatation and curettage, D&C, is dilatation of the cervix and scraping of the endometrium. It is both a diagnostic and therapeutic procedure. Indications include persistent uterine bleeding, endometrial hyperplasia, polyp or carcinoma, retained product of conception with incomplete abortion. Coldocentesis is the aspiration of fluid by insertion of an 18-gauge spinal needle through the posterior fornix of the vagina into the pouch of Douglas. It may be used in suspected ectopic pregnancy by identifying a non-clotting blood in pelvis. Blood that does not clot on standing is evidence of intraperitoneal bleeding. Clotting blood may be a form of punctured vessel. However, failure to obtain the blood is non-diagnostic. So, we're going to look at the ultrasound technique for evaluating the gynecologic scan, and there are several of them you could use. The techniques include transabdominal sonography. You have an endovaginal, or what you call a transvaginal sonography, transperineal or translabial sonography. You can use a transrectal sonography. You could evaluate your pelvic scan through sonosalpinography or sonohysterography. Let's take a look at transabdominal sonography. How do we prepare our patients, and what position should our patient occupy during this technique? So a reasonably filled bladder is required for transabdominal sonography. Patients are instructed to arrive with a full bladder by drinking about, depends on your measurements. Some measure in cups, some measure in O's, depending on your volume of measurement. So they drink that volume of water 1 hour before the scheduled scan. Now, the bladder volume is obtained when the bladder has a triangular shape and the fundus of the normal non-gravid anteverted uterus is covered by the bladder. Now, if the bladder is over distended, in other words, the bladder is too full, it appears round and it's very difficult to scan. So if the bladder is not adequately distended, in other words, under distended, the normal uterus also will be difficult to visualize due to interference of the overlying bowel gas. Now, in patient position, the transabdominal exam is performed with the patient in a supine or recumbent position. Transducer selection, you choose your probe, typically about 3 megahertz to 5 megahertz, and a plane of section the image orientation, as you see in these images. When your patient is properly oriented, these are the image you see, and there's a schematic diagram to give you an idea of organ relationship vis-a-vis the probe placement. The four directions in sagittal transabdominal scan images, as with respect to the current AIUM standard. In sagittal transabdominal pelvic scan, anterior should be at the top of the screen. The posterior should be the bottom of the screen. The cranial or the superior portion of the scan view should be on the left side of the screen, or the caudal or the inferior of whatever image you are looking at should be on the right hand side of the screen. Now, the four direction in transabdominal image that we mentioned will be helpful when to understand what you're seeing on your screen vis-a-vis the patient orientation and the image presentation. For transvaginal sonography, the patient preparation and position for transvaginal sonography, the patient bladder should be empty as opposed to the transabdominal. The patient bladder will allow, the empty bladder will allow close proximity of the transvaginal transducer to the body of the anteverted uterus. Now, with bladder distension, the anteverted uterus is displaced cranially outside the effective view range. The patient position in this ultrasound, TVS, is performed ideally in a gynecological examination table with patients in a lithotomy position. Now, the position enables free and unobstructed movement of the probe in both vertical and horizontal direction. Now, if a regular flat table is used, the patient lies on her back with legs bent approximately shoulder depths apart and the feet flat on the table. The position limits the vertical and horizontal movement of the probe, but usually permits evaluation of the pelvis. So TVS probe selection are typically from 5 megahertz to 10 megahertz with the average frequency of 7.5 megahertz with a shorter focal distance of 2 to 12 centimeters. Now, this higher frequency provides superior resolution, very high image quality with smaller field of view. Now, transvaginal sonography probe may end fire, angle fire with straight or curve handle. I will show you some of the examples. So the planes of section and image orientation is as shown in this image, the sketch, and the ultrasound image. So 4 directions in the sagittal transvaginal image as per the AIUM standards. In sagittal transvaginal pelvic scan, the caudal part is seen at the top of the screen. The cranial part is seen at the bottom of the screen. The anterior part is viewed on the left side of the screen, and the posterior part is viewed on the right-hand side of the screen. So, transducer preparation and how do you care for your transducer in TVS. Now, small amount of gel is applied to the tip of the transducer. Now, the probe is covered with a disposable barrier, usually condom, prior to the insertion. If it is a condom, it should be non-lubricated and non-medicated. Now, care should be taken for patients with history of allergy to latex. So you want to ask your patient whether they are allergic to latex. And if they are, they will use other options. But if they are not, well, take due diligence to find out for your patient so that you don't leave anything in case of medical legal issues. In such cases, non-latex polyethylene condom is used. To ease penetration into the vagina, a standard aqueous-based lubricant is used to cover the tip of the transducer. The probe may be introduced in the vagina by the patient or the sonologist. So in some cases, personally, I may ask the patient if they want to do that, but in most cases, they just want you to get on with it and carry on with your exam. So a female member of the staff or chaperone must be present during the TV study. It's very important, for issues around medical legal matters. The operator should always wear a glove on the scanning hand, and care should be taken to ensure that contaminated gloves do not contact with the ultrasound control panel. Now, after completion of a TV scan, care should be taken not to contaminate the probe with secretions from the patient when the probe cover is removed. The operator should thoroughly wash his or her hands with soap immediately after the scan. How do we care for our transducer? Now, transvaginal probe must be handled appropriately and clean between patients. So if you are doing a battery of TV studies, in between patients, you clean your probe properly before you see another patient. Gel should be thoroughly wiped off the probe using running water and dried off with soft cloth or paper towel, according to 2003 AIUM number 2. So it should be, the next thing you do is it should be disinfected with the use of a liquid chemical germicide according to the level of direction by the manufacturer. But 99% of microbial load reduction results from adequate washing with soap and water. Chemical disinfection provides additional margin of safety. The commonly used disinfectants are glutaraldehyde products such as the Cidex and metricide and so on. Glutaraldehyde products are not carcinogenic, neither are they teratogenic, but they are classified as irritants and potentially toxic to the health worker and the patient. So after the use of glutaraldehyde product, the probe must be rinsed with water to remove all the traces of disinfectant prior to its use again. So what's the difference between transabdominal and transvaginal scanning? Let's compare and contrast the both technique, how they complement themselves and how they are not mutually exclusive. So transabdominal scan, the advantage is you have greater depth and field of view, and you can see the entire pelvis. You can evaluate a large mass. You can evaluate mass that are out of the range of the TV probe and can be used in patients with intact hymen. So in the case of females that are virgins, you don't have to do a vaginal scan. Just go ahead with your transabdominal. And transabdominal can image more than one structure simultaneously at a time. For example, both ovaries. You can see both ovaries on one field of view. And they are able to scan the upper abdomen where it is required. Well, the disadvantage with transabdominal scan, it requires full bladder, and full bladder will require time for the patient to feel and may cause pain during the examination, a pain or leakage, depend on, and sometimes you want to apply some pressure mistakenly. So some patients cannot adequately feel their bladder, and you could have difficulty to evaluate retroverted or retroflex uterus on transabdominal. There's also difficulty to evaluate obese patients, reason for the alternative TV scan. So recent surgery or scarring, barium or air-filled bowel will limit access. So what are the advantages of transvaginal scans? So transvaginal scan advantages would include proximity to pelvic organs with higher frequency transducer that allows better tissue characterization. It does not require full bladder. That means it saves valuable time. Empty bladder scanning is less painful. It's good for obese patients and patients with abdominal scar from recent surgery. It's better for evaluation of retroverted and retroflex uterus. TVS has better visualization of small uterine fibroids and small adnexia masses. It allows earlier diagnosis of intrauterine and ectopic pregnancy of about 1 week before you see it in a transabdominal exam. It permits better visualization of embryo, the morphology in the first trimester and early second trimester, and it allows for early diagnosis of some congenital anomalies. TVS will permit better visualization of the cervix and lower uterine segment for diagnosis of cervical incompetence and issues like placenta previa. Now, it is considered, as TVS will be considered, an intrusive but non-invasive technique. The disadvantage of TVS is limited, or it has small field of view. Masses that are out of range of the probe are missed, and cannot be used in patients with intact hymen. Again, we face the problem of patients' acceptability, and some will not be comfortable with it. Some patients may not be able to tolerate TV study. For example, patient with severe vaginitis or vaginal stenosis, and TVS has limited probe mobility. Other examination technique that can be used here is sonosalpinography or sonoisotography. The techniques, you have a warm fluid or saline or contrast agent that is injected via a small catheter to distend the lumen of the uterus and delineate the abnormalities using sonography. The indication for this type of exam is used to evaluate tubal patency, uterine anomalies, adhesion, polyps, submucosal fibroid, differentiation between sessile and polypoid mass, can explain persistent bleeding in patients with normal endometrial biopsy. Now, the guidelines for gynecological ultrasound evaluation and documentation is as follows. The uterus, you need to identify the position and the shape of the uterus, then the size. Then you measure the length, height, and the width of the uterus. The endometrium, you assess the thickness and the echogenicity of the endometrium. Endometrial canal should be evaluated. The endometrial cavity should be evaluated. The myometrium, you assess the echogenicity and how uniform, the uniformity. Then evaluation, the guidelines for evaluating and documenting ovaries. You look at the size, the volume, the shape, position, and echogenicity. And when you measure the ovary, you're measuring the length, the height, and the width, and we give you the volume. So other pelvic structures that you can visualize are called the sac, the bladder, the pelvic musculature, and vasculature. So this is the introduction to gynecologic sonography. This information will help you form the basis on which every other information we're going to discuss will be built upon. Thank you for joining on this lecture. Please like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send an email to me at sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144175, or you can visit our online store at sonoeyes.business.site. Until next lecture, when I come your way again,